initially we were going to ask the patients the questions, but I thought it's probably easier if we mix it up, and John had a good suggestion that we have opportunity for the patients to ask the doctors the questions, and then the doctors ask the patients a question, so we have a bit of back and forth, or a series of questions between, to find out your questions and then see what the doctors want to know from the patients about the patient experience, what else we need to do at either a state level or a national level, those sorts of things. So maybe we'll start with an audience question. So, so a patient, anyone who wants to ask a question to Svetlana, wants to join, wants to ask the question to any of the doctors or any of the other patients, just open the microphone up to that to start with, and then so we'll have a bit of a discussion, and then we'll switch it around, and one of the doctors can ask one of the patients or ask some of the patients a question. So does anyone in the audience have a question they want to put up for discussion? Okay. Right. 1, 2.
My question is, when you're first diagnosed with an ocular melanoma, should you be referred to an oncologist?
Medical oncologist? All right. Bertil, do you want to answer? Have one microphone along here, and then I'll have this. This will be the roving microphone.
It really depends on which part of the world you live in, because different resources vary from place to place. I can only say what I do. What I do is try to do a biopsy on everybody, or get my retinal surgeon to do a biopsy on everybody. And if it shows lethal mutations, then they go to an oncologist. If I consider the risk of metastasis to be very, very small, then I don't usually send the patient to an oncologist. But other ophthalmologists may think differently, and oncologists may prefer us to work differently.
What we start with is our local doctors. I think that we had a mention from our GP down here, because one of the things that people need is someone medical that they can talk to, for a start, about life in the universe. One of the slides I showed was that if you've got a small melanoma, you've got 1% mortality of melanoma related over 5 years, but you've got a 6% overall mortality. And we're dealing with an age group that sometimes is older, and it is important to understand that they might have all sorts of other things. So before you start even thinking about therapy, I think that it is important to engage with them, with their local medical care. And it's also important because then they've got a pathway. If something happens at any point in time, that GPs actually know what's going on. So we try and get our initial screening done through a GP at a very simple level of scans and blood. And the other part about that is it doesn't delay us getting on and doing something, because one of the problems of getting into major cancer centres for screening tests is that it's not the highest priority in a time sense, and our patients often feel that treatment is getting on and having your eye treatment is a high priority. We still don't really have strong guidelines other than practical time intervals for getting on and treating things. I think in skin melanoma they sort of give 14 days of diagnosis to treatment, and that's because you're concerned about it going from one risk level to another. In ocular melanoma, it's not necessarily progressing at the same rate, but I think the psychological imperative to get on with treatment is important. Max, maybe where the people who see patients, what happens up on this far north?
Can I just ask you? Can I ask a clarification of the question? Are you asking should patients see an ocular oncologist or an oncologist like Anthony who gives?
Well, I was diagnosed 3 years ago next month, and there was 10 days between diagnosis, and the only option really available to me was enucleation.
Mm-hmm.
And at no time in those 2 years post-enucleation was I ever heavily suggested that I should see an oncologist or medical oncologist. And so my brain went, well, I've had cancer. Should I not, what sort of surveillance should I be getting? And
Right.
yeah.
Okay, so I just wanted to clarify, because we talk about ocular oncologists, people like John and I, who are kind of surgeons but trained in this area, and I'd say everybody that has a potential diagnosis should see, in Australia, an ocular oncologist or retinal specialist, because they're the kind of subspecialists that deal with it. So that's the first sort of port of call. But then the oncologists, people like Anthony, and as Bertil said, every state and every jurisdiction, it's going to have different, not ideas, but different access to these resources. What we do in Sydney is I offer all patients the possibility of seeing a medical oncologist, actually before we treat. Because, as you know, before we treat something, we need to find out information about it, we need to stage it, and I tell patients that, we have a sort of pathways here through Kinghorn Cancer Centre or the Melanoma Institute, and I offer that possibility that they have their initial workup and discussion with another specialist who knows all about uveal melanoma with an oncologist. Some patients say, I don't want to bother about that, I live a long way away, I've got a good GP, and that's fine. I'm happy to liaise with the GP or local doctor initially. Similarly, after the treatment, after Svetlana's done her job and we get back the pathology information, once again, all my patients, I do offer that possibility, just to know that they're in a pathway with someone who knows all about uveal melanoma, or even just an initial baseline visit with an oncologist to sort of have a screening program worked out for them, and then they can go back to somebody, we can communicate, or the oncologist can communicate with a local specialist or local doctor who can then sort of follow through with some guidelines about what surveillance or what screening is appropriate.
Is that on? Yeah. A question about after radiation, if you get the tumour shrinking, is that a good sign as far as it's spreading elsewhere? Is that a really good sign, or is it pretty irrelevant?
We did a study on that, and after plaque treatment, it doesn't correlate with survival. With other kinds of treatment, like proton beam treatment, then perhaps it correlates with survival. But with plaque treatment, you're giving such a high dose of radiation to the base of the tumor that it's just blasting all the membranes, and so the tumor shrinks. Whereas with low-dose radiation, you're preventing the cell from dividing. So the cell doesn't die until it reaches old age. And the faster it grows, the faster it shrinks. But when you give high-dose radiation, it's a different kind of story. But we have a radiation oncologist here. She's much better qualified to answer than me.
Well, I generally would agree with what Bertil said. I think proton radiation actually is very high dose. Yeah. Biologically, it's a higher dose. But I think we haven't determined that there's a population for whom progression in the eye leads to a poorer outcome. There might be a group, like in lots of cancers, if you don't get good local control of the primary, there may be a small increased risk of getting secondaries one day that weren't there before. But it's hard to measure and to prove that, and it's never been found in eye melanoma. Just whatever kind of radiation's used. Radiation's just radiation. The only difference between the radiations is the physics. Really, there's some subtle biologic differences between protons and photons and beta particles, but they're not of any significant difference in terms of cancer treatment. It's not like having 5 different drugs. It's essentially the same drug delivered in different ways.
The shrinkage is not the killing of the cancer.
It's not going to necessarily prove to you that you're cured. That's right. It's cured in the eye, but not necessarily elsewhere in the body. That relates more to the genetics and the size.
So I think the principle is if it's spread, it's probably spread before you've had the plaque put on. So it doesn't matter. It's just a random event. So if you're unlucky enough that the cancer has spread, it spread probably even a month or 2 months or 6 months before you saw the ocular ophthalmologist to put the plaque on. So if it hasn't spread, it hasn't spread. But unfortunately, we've got scans, and that's the only way that we can tell. We can monitor it. So the point at which we find it, then we know that it's spread. But when it's spread, there's a complex analysis in terms of understanding when cancer spreads, and we just don't know. Sometimes the cancer will spread and just sit in the liver. So I saw a lady about 10 years ago. She had her eye treated at Wills. She was 13. Her tumour came back when she was 42. So it just sat in the liver for 30 years and didn't do anything. So, and you couldn't even see it. She had lots of scans, and after 20 years of scans, she stopped doing scans, and then one day, Christmas Eve, she had some pain in her liver. She got a scan. They said, there's a tumour there. Biopsy, it was the same tumour it was back when she was 13. So it had just sit there for 25 years and did nothing. And it didn't even grow, but something happened and it started to grow. So that's sort of the physiology of the thing. So now I guess it's a turn for one of the doctors to ask the patient body any questions in terms of, I guess, needs, wants, etc., etc. Does anyone want to, and the doctors or the paramedical people want to speak up?
I was going to ask a question about one of the big things that we've heard is establishment of protocols for that follow-up. And I think one of the things that we've heard is that there's quite a vast array of different sites that people get it from, either the ocular oncologist, their cancer specialist, their GP. What do the patients feel is the most appropriate thing? Because it's all very fine being sent into the Kinghorn Centre, but if you live in outer Western New South Wales, you might not be so happy about that. And certainly, if we're going to advocate that this is going to go on for 10 years or more, it may become an impractical thing, particularly, as I said, if you've got a greater chance of having a heart problem rather than a melanoma. Where do our patients feel that they would like their follow-up therapy or follow-up review at a systemic level?
The Kinghorn and Peter Mac have got now cancer telehealth programs. So we do telehealth. I know Peter Mac have got a very robust cancer telehealth program. So that might help with that. But does anyone want to answer? Yep, in the back.
I'd just like to say, personally, I feel much more comfortable since I have been seeing a medical oncologist. So I had my treatment a few years ago, and I initially didn't have any contact with a medical oncologist. Since starting that process, I just feel more comfortable in myself. I feel like somebody's in charge and somebody knows what they're doing. And my medical oncologist has been really interested to find out what the outcome of today's program and yesterday's program is. And I think as patients, we need to advocate for our own ongoing treatment and do what works for us. And what works for me isn't necessarily going to be the same as what works for somebody else. But I just, having spoken quite widely with a lot of people on our Facebook forum and locally, when you live in somewhere like Canberra, you're isolated from your original treating specialist. You do get sick of travelling up and down to Sydney, and so having somebody who now in Canberra, we've got Dr. Peters, who is just really focused on helping those of us with ocular melanoma to decide what we want to do. But it is a personal choice. And I've had many discussions with him about what is right. I personally have a PET scan because that's what I originally had, and that's what we decided to continue doing. But I do think there is some confusion as to whether you should have a PET scan or a MRI or an X-ray or, a CT. So I think standardised surveillance guidance would be really good.
John mentioned sort of, going to the Kinghorn Cancer Centre, and perhaps I didn't express myself very well there, but what I was trying to say earlier was that I always offer that option to people. You know, I'm not saying that they have to go to Kinghorn in all instances, but it's an option of a resource. They've come to see me in Sydney. It's a resource also in here in Sydney that they can go and see and utilise and get some information. Then they can make their own mind up whether they want to continue at Kinghorn or whether they want to have the care in Nowra or Canberra or wherever. And if that's the patient's choice, then we support that and facilitate it. And if we've all seen the patient here as a team, including the guys at Kinghorn, then we're sort of on the same page and we can help the local person do the follow-up. Because there are some areas, you know, where oncologists don't see a lot of uveal melanoma, and they're really looking for some guidelines and support from us.
Can I just finish on that? Just because I'm worried I might have not expressed myself properly. In Liverpool, for instance, where I was able to biopsy everybody, then I was able to select which patients went to the oncologist or not, in discussion with the patient. At Moorfields, where they don't have the same luxury that I did have, and for offering biopsy to everybody, and when I can't do biopsy, then all the patients go to the oncologist. When the patients tell me that they can't keep coming to London or Liverpool for their screening, I try and encourage the patient to see a specialist oncologist at least once. And then the oncologist will know the local expert close to the patient's home, or will advise the local oncologist on how best to screen. With regards to the PET scans and all that, there is a concern about the amount of radiation that patients get over many years when they get CT scans and repeatedly and so on. But I'm not the best person to discuss that.
Is it actually on? Yeah. So for me, obviously, I saw Dr. McKenzie when I was being treated, and after my exenteration, I was then transferred to the Peter Mac. And I think one of the things for me is I had a spread within 12 months. And there had been, I guess, a lack of guidelines as to when the scanning should be done. Initially, it had been discussed that I was going to have scans every 3 months. And after 2 sets of scans, they, the oncologist that was looking after me decided that could be pushed out to 6 months. And it was in that 6-month gap that I actually had my seizure and was diagnosed stage 4. So for me, I think there needs to be some guidelines as to exactly how often those scans are happening, and when you start pushing them out, because otherwise we're just making stabs in the dark, and there are things that can be missed. And I just, for me, I know it wouldn't have changed the outcome, but I would have potentially been diagnosed maybe a month before and not have to go through the trauma of a seizure at home. So that's just my point of view on that one.
Yeah, sorry. We all want to say something. Look, it's as a clinician, it's somewhat difficult. Certainly, when I look after patients want a high degree of certainty, and the issue with dealing with a rare condition is, there is research on it, there is data, but there is also not a high level of certainty around a whole lot of these things that we're talking about. And so I suppose as a clinician, I'd say to patients, you actually do need to be patient and understand those sort of concepts. As I understand it, and again, a lot of this stuff seems to come from America, where they do a whole lot of surveillance, most metastases in uveal melanoma go to the liver. And consequently, a lot of the focus is on looking at the liver, usually with an MRI, simply because it offers a high level of detail as far as the size of the lesions they find, but also because it doesn't involve radiation. So it's reasonably safe long-term, although there are some issues about the long-term effects of gadolinium, which is the contrast agent, and a whole lot of work is being done on using no contrast type scans, but that's we probably need an imaging expert here at some of these next time, maybe. So I suppose I'm going to put Anthony on the spot and ask a question that bothers me. Surveillance for non-liver metastases. What is your feeling about how often we need to look at the lungs, and how do we look at the lungs?
So Bertil was involved in some research, and they found that if you did MRI scans on high-risk patients every 6 months, 92% of them, MRI of the liver, 92% of them were found. So I rarely see patients that recur without having a liver metastasis. So it happens, and sometimes they recur in lymph nodes. Rarely, in this young lady, for example, she recurred in some lymph nodes in her chest. So it does happen. I guess to mitigate that risk that just looking at the liver won't pick up everything, then I will do some CT scans, a CT scan of the chest, especially in a high-risk patient. Maybe not quite as frequently. If I'm doing the MRIs of their liver, let's say I do MRI of the liver every 3 to 4 months in the first few years, I will, especially in a high-risk patient, do a CT scan of their chest, perhaps every second or third MRI, just to mitigate that small risk that they're occurring outside their liver. But the chance of occurring in their liver, the chance of catching something which is bound to recur in their liver is over 90%, so it's down to a small percentage. If someone's having a CT scan, then it's very easy, because they can't either afford MRI or can't get an MRI, it's very easy to do a CT chest abdo-pelvis. And I have a few of my patients that can't access MRIs, and we do CT chest abdo-pelvis, so they're having a PET scan, for example, which you can get them under Medicare for melanoma. The government doesn't ask what type of melanoma. Then you can just do a CT chest, you can just do a PET chest abdo-pelvis. So it's very easy to do that, radiation issues aside, to do that. And so to some sense it's individualised, but I'm cognizant of that, and will tailor the scanning to their risk and time, etc., etc. So Glenn, did you want to say something?
I was just actually, probably should have come in before your little talk then. I saw Dr. Joshua before and after my procedure, and then I made the decision to see someone local because of the distance. And when I saw that local oncologist, I made it clear to him that he's there for monitoring, and if any anomalies are showed up, I'm back up here to see someone who really knows what they're doing. And he was quite happy with that, knowing that, if anything showed up anomalies, then that was his job to look after me just for that monitoring period. And so that's what I'm doing. And so far I'm all clear. Well, actually, he did pick up the breast cancer, which was lucky for me.
But you didn't get back to him?
No.
No. I don't do breast cancer. Okay, great. Joe, do you want
I'm going to ask a question I think I know the answer to from this group, which is, have you come across any patients who have had success in boosting their immune system with some alternative treatments and then seen a tumour regression in some way? Other than traditional...
Those drugs that I mentioned? Other than the ipilimumab and nivolumab?
Yeah, every expert in the world I've spoken to, I've said, have you seen any wild and crazy treatments that have worked? And I think I know from this group you're going to say, Jodee, you're a crazy person for asking that question. But I'm going to.
It seems like some other people want to have a word in, so let me hand over to the.
The problem of medical studies is that if there was a particular treatment that had 1% effectiveness, you would find that really very hard to show itself. But if you were that 1 in 100, you'd be really very grateful for it. So the way I approach it is that there is no proven lifestyle adjuvant therapy, but that doesn't mean to say that one doesn't exist. And I leave it open to my patients to explore lifestyle choices. Most of those lifestyle choices are actually going to affect their non-melanoma mortality. And I think that that's important, because you've got to remember that unfortunately all of us face a 100% risk in the long term. And if we can improve that, that's a really good thing. Whether it improves their melanoma-related mortality, I'm not so sure. But, I think it's an open area. That's my view.
I think, just to reply to that for a moment, it's crossed my mind that a very perverse symptom of ocular melanoma for me is that I'm working even harder to have a happy life. And that's so perverse.
Well, I've had several patients tell me, 10 years ago when my melanoma was diagnosed and treated, I thought it was the end of the world, but in a strange way it's been a blessing in disguise, because for the past 10 years I've enjoyed life so much more. I've not bothered about things that weren't important. I've focused on what I wanted to do instead of what I had to do, and I've stopped doing this and started doing that, and it's really improved my life an awful lot. And so many patients have told me that. Is that what you're meaning? With regards to strange treatments, I have a patient who had a very big ciliary body melanoma and monosomy 3, and he should have died soon after. But he went to see various oncologists who all declined systemic adjuvant therapy, because the systemic adjuvant therapies have got side effects, and so they only wanted to give him those drugs as part of a clinical trial, and there weren't any clinical trials at that time. Eventually he found an oncologist who did give him a drug, vorinostat, and he's still alive and well and healthy 7 years later, and he's broken all the rules, and I'm delighted for him. And there might be something in it sometimes. There's a big dilemma as to how to manage a patient like that who does want to expand the envelope.
That's true. So vorinostat is a drug that's called an HDAC inhibitor, and so theoretically, at least in cell culture, the cells change from the aggressive type to the less aggressive type. And people have looked at that in patients with metastatic disease, but no one's tumour shrank. So when the disease is more established, it's probably too late. The question is giving it to people when the disease is less established, and can you slow it down? The trouble is the drugs, A, not available, and B, toxic. So if you're well, are you going to make yourself unwell for years? So you probably need at least a year or 2 years of treatment to have any meaningful impact on the disease for something you may not need to have taken anyway. And so as an oncologist, when I have conversations with patients that have run out of options, and when I have those conversations, it's let's try the crazy shit. Then we have the patients that have only started options, and we say, here's 1, 2, 3 options for you. But then the conversations with patients that haven't tried anything and may be cured of their cancer, we're very, very careful about suggesting treatments that are unproven. So in colon cancer, for example, if you have your colon removed, then there's very good evidence from thousands and thousands of patients that getting treatment to kill off any spare cells that have escaped, even though it makes you sick, will help you live longer. But when we have conversations with patients who have metastatic ocular melanoma, or who have ocular melanoma that's been resected, giving them a drug that I don't know is going to work, and there's a few people advocating such drugs in the United States, which definitely make people sick, diarrhea, high blood pressure, skin rashes, sore mouth for 2 years before you can think that they could possibly help you, and even then you may not need in the first place. It's a very difficult thing to recommend ethically and legally, because you may end up dying from taking a drug you actually didn't need in the first place. So we will need drugs that work very well to kill the cancer before we start having those conversations that those drugs should be given to people to prevent the cancer coming back, because the stakes are so high. The stakes are much lower in someone who's done everything they can, they want to do something crazy, And I have those conversations with patients because if they don't do anything, they're going to die in 3 months. But if we may as well try something, and say they're a bit nauseous for a month, but they live for 2 months longer, then that's great. And sometimes they're very grateful. But it's a whole different ball game when you're dealing with patients that may not have needed any drugs at all in the first place. But to get back to your question, the answer is no. So I haven't seen anyone take anything to boost their immune system. And I'd be very wary of people selling you stuff telling you it boosts your immune system other than those drugs there, because it doesn't boost anything other than the person's pocket that's selling it to you. Max, did you want to say something?
No, not really much else except to say that I think a lot of them haven't been studied, so it'd be interesting to do some more studies. I think most of them are understudied. But I don't know of anything. But another thing which I became aware of, I think you can Google it, is an Oxford scale for assessing medical evidence. I think it's 1 to 5. Level 1 evidence is if a patient thinks it works. Level 2 is if a doctor thinks it works. Level 3 is if more than one doctor. And right up to a randomised controlled clinical trial. So if you're looking at stuff on the internet, trying to work out is this any good or not, of course you can ask a health professional, but you could have a look at that scale and decide what you think the level of evidence is, 1 to 5.
Yeah, just a quick question on the back of that point, Max. It leads into a second point I'd like to raise. So on the internet, so actually backtrack a bit, I'm involved in radiotherapy advocacy through the Targeting Cancer campaign, which is about 6 years old now, which is an effort on the part of our tripartite college in our discipline to get the right message out to consumers here in Australia and indeed around the world about the safety, efficacy and cost effectiveness of modern radiotherapy when done well. An important aspect of that work is to collate all this material online and make sense of it and point people online to resources outside of our Targeting Cancer website that have been vetted by experts with consumer input. And so I think with these rarer diseases, the resources online are just everywhere, right? And the quality of those resources are variable. And then you've got social media, and so it ends up being this dog's breakfast, and there's a lot of false hope being pushed online, sometimes in the complementary and alternative medical space, as an example, but not just there. And so I'd like to sort of make the point that there's this wonderful new website that Anthony has put together, and I think it can be a great conduit for patients and their carers and loved ones looking for quality information about this disease. That also touches on many of the questions that the consumers have asked of us over the last hour or so. And so in another effort in the particle therapy world that Claire is also involved in is this effort to do the same thing for proton therapy, because indeed there's variable information online. And so we've made an agreement that consumer-led involvement in the design of resources that we would oversee is so critical to get our patients reading the right things and avoiding things that are not perhaps that accurate. So I would encourage the consumers in this room to come together if that was possible. It is challenging because many of you live all around Australia, but I think there's a moment here in history, in the early phase of this group, where you can galvanize your experiences and your hopes for yourselves and your family to make something of this. And perhaps this website, I don't know if I'm talking out of line, Anthony, but may or may not be a good vehicle to put patient stories up and maybe some videos, and then help other patients and their carers navigating the World Wide Web into the right place.
Thanks. I just wanted to ask a question about I'm getting the impression your immune system can attack cancer that it's trying to spread, but I may have that wrong. But if that's right, can you make your immune system work most effectively by good diet and exercise, or is that irrelevant? I don't know if any doctor wants to.
I can answer that. So in some cancers, it's very important. So in skin melanoma, for sure, the immune system is important. And so I tell my patients that I had a patient who he called it the 3P diet. It was pizza, pepperonis, and pierogies. And so he got metastatic cutaneous melanoma. Then he exercised a lot, and he dramatically changed his diet, and actually his melanoma actually shrunk. That works well when your immune system can see the melanoma. So that happens in cutaneous melanoma, because for some reason the immune system sees cutaneous melanoma. And the only thing he did was to have a better diet, and his immune system shrunk. For some reason, the immune system doesn't see ocular melanoma well at all. So you can, and even if we give these powerful drugs which stimulate the immune system, even then it only works, and they're very powerful, even then it only works at most in just over 10% of people. So you can imagine if we're giving hugely powerful immune boosting drugs and it works in 10% of people, changing your diet is unlikely to do it. You should change your diet for other reasons. So the Cancer Australia recommends now that every cancer patient has an exercise program, and every cancer patient has also a healthy diet prescribed by a dietitian. That's part of the national guidelines, that every cancer patient has an exercise program. That helps you. Every human being should have an exercise program. But there's government endorsement of exercise for cancer patients, for sure, there's no question. And that probably the same thing probably goes for diet. But we can't as yet suggest it makes any difference to treatment, to ocular melanoma in particular.
Anthony, that's really good. Obviously, I missed out on some of that advice at some stage. Speaking of missing out on things, and I hark back to the original question about whether everyone with ocular melanoma needs to see a medical oncologist. A thought came to me over the course of this time that the state of mind and your mental health is really important as far as dealing with cancer and as far as surviving cancer. Lots of studies have shown that I suppose the more the better you are at coping with things, the less likely you are of succumbing from the disease. I'm just wondering, should every patient with ocular melanoma see a psychologist, social worker, something like that? And I suppose the reason I'm asking this is that most of our eye treatment, apart from those that are getting stereotactic radiotherapy, are probably going into very isolated units. We've got the eye hospital in Sydney, we've got the eye and ear in Melbourne, where there's not, it didn't strike me as being a huge team approach. And I'm just wondering, maybe the ocular oncologists that are here might wish to push or promote that.
Thanks, Ian. Look, I think that's something where we could definitely improve things. You know, I think I know at the eye hospital in Sydney we do have a social worker who is supposed to be available for patients, and part of the problem is getting continuity of people. You know, you get a social worker or a psychologist who's on the staff, they're there for 6 months, 12 months, and then they're gone, then somebody else, you know. It's a matter of just keeping the eye on the ball there and trying to get some continuity going, and also some level of expertise in this sort of boutique area, I think, is important. But, you know, I think that's something we could work on as a group to try and improve the support that we can offer through an institution. That would be an ideal starting point, I agree.
In Liverpool, because I had 300 patients with melanoma per year, I had a psychologist full-time just for my patients. And she saw every patient in the ward the day after their operation or just before their operation. And then when we had our MDTs, she had to give us an anecdote once a week to educate us on something that we as ophthalmologists would not think of, about the psychological impact of family or other conditions on the patient. So we learned a lot from those anecdotes from the psychologist, and the patients benefited an awful lot. But that was a very unusual situation where we were lucky enough to get that funding. At Oxford, I tried to get to send a patient to a psychologist, and they said, sorry, there's no funds for us to provide psychological support. In San Francisco, there was a psychologist, but she was in a different hospital, and the patients found it too difficult to travel to a different hospital. In London, there is a psychologist, but in another hospital. So it's something that's really, really helpful to patients. It's very important to tell, I've found it very important to reassure patients that psychologists are very different from psychiatrists. Psychiatrists look after patients who are mentally unwell, where psychologists help normal, healthy people cope with very difficult situations. Because I've seen that many patients don't want to see a psychologist because they think it's a slur on their personality or on their ability and so on. But I keep saying that this diagnosis can knock anybody sideways in a very unpredictable way, and I've seen patients benefit a lot from seeing a psychologist. If a psychologist is not available, then a well-trained nurse can provide an awful lot of emotional support. And in oncology centers, nurses have to have special training to deal with psychological problems, as far as I know.
Thanks. I completely concur with what Bertil said. I obviously work in a cancer centre, so we have the luxury of routine involvement of specialist nurses and very good access to psychology. But for many people who, first of all, freak out at the idea, and I find that's quite common, even if they well understand what a psychologist is, they feel, oh, I don't need that, but maybe later they need that. So it's always important to raise the possibility that this is always available. It doesn't not something that it's a yes or no and you never get another opportunity. And the other thing I think that's important to think about, my observation of my patients in general, not just eye melanoma patients, is that sometimes it's actually only one visit or maybe a handful of visits to the psychologist that's actually required, because often it's just an opportunity to talk to somebody who's not a family member, because much as family members want to love and support you, they're often so emotionally engaged that it's very difficult to have these conversations together, and you just want to have an opportunity to express how this disease is affecting you personally without upsetting your partner who you're trying to protect from these bad emotions. So maybe only be one visit or two visits, and that can be a very productive thing. And also Medicare, of course, funds, you'll know better than I, 5 or 7 now? 10. There you go, it's going up by the minute. Medicare rebated visits to any social worker in the community. And I think that's a resource that you should really tap into if you need to, with a relationship with your GP, because the GP will usually be somebody that you know better than your treating team.
Can I just add to that as well? I mean, there also are online availabilities there with on the Cancer Council. You know, I'm in that AYA group, so there was also Red Kite available to us, and they were just online available, psychologists, counsellors, 24/7. And to be honest, I mean, I was treated at Peter Mac, so I had the blessing of having that available. But in my earlier stages as well, I wish I'd sort of thought about the psychological help, because, as I said, I felt so alone. And I think so many people feel so alone. And just having someone else there to talk to that had an understanding, but a removed understanding of what I was going through, I think would have been very valuable in the early days. So it's not something to be scared of. And yeah.
I'd just like to go back to the issue of a pathway, and I likened a pathway to a list of ingredients, and they've often got little arrows that go between all these boxes of where you come from, you get diagnosed, you get treated, but it's got lots of things that come in from the side with sort of two-way arrows, and we need to understand, I suppose, what needs to be in all those boxes, and certainly psychological support needs to be one part of it. How you provide it, what the actual worksheet looks like in your institution will vary enormously, because it'll vary on patient choice, patient location, and what the institution can actually provide. And but it is part of patient advocacy needs to say, look, this should be a part and parcel of what normally goes on, and particularly most patients in the age group, you're an exception, but most older patients are visiting their GPs, X number of times per year. I can't tell you exactly. And they've got, direct access through referral to that. And I think that's a really good way. The problem of doing it as an eye practitioner is it's often very difficult, just as it's difficult for us sometimes to send people to low vision services. You kind of think it would be pretty normal if someone couldn't, but very often when people have lost vision, they're not ready to seek support at that point in time, but they are at some point in the future. And I think that's where having their medical care pathways involving their GPs, having a pathway back to their eye practitioner, having a pathway back to an oncologist is important, so that the patients can understand, yes, they can go off to see a psychologist, they can go back to their cancer centre, and go to their GP. There's lots of different pathways. I don't think there's just one.
John, on your last 3 slides that you presented, you mentioned OCPs.
Yes.
What's the value of an OCP to this group?
Well, I'll tell you the value to me is that when I go and see the administrators at the Eye and Ear Hospital who don't understand what problems I have or what problems my patients have, if I have a document that says this is what we should be providing, these are the ingredients, have we got them in the cupboard? And if we say no to 70% of them, well, what we're saying is, well, we need to change our internal practices. And you'll never get 100% of those ingredients in any institution or for any patient. But it enables me to then stop whinging, because otherwise you're labelled, they don't listen to you if you just whinge. But if you come with a solution, and that's what, to me, an optimal care pathway is, a solution to the problem that the hospital has to deal with. That's the benefit to me.
And so us together, are you saying that's one of the things that we should, the consumer seems to have a voice here? What can the consumer do for you?
I think the consumers can say that even for rare cancers, doesn't matter whether you've got a rare cancer or a common cancer, you should still have access to the same general list of ingredients. Just because you've got a rare cancer doesn't mean to say that everything on the breast cancer or skin melanoma cancer ingredient list shouldn't be available to you. It should. It's just that because they've grown up in eye hospitals or wherever they've grown up, they don't exist. Doesn't mean to say they shouldn't. And that's, I think, general advocacy for appropriate care is really what we're saying. We shouldn't limit it just because we happen to have an eye problem. I mean, cancer, vision loss is a, if you ask people in the community what do they want to treat, well, they want to treat vision loss and they want to treat cancer, and this is where we've got two things combined. There's a good couple of reasons that you should be able to have psychological support, along with a whole lot of other practical things.
That's a very important point. The difference between patients with ocular melanoma and patients with breast cancer is that patients with ocular melanoma tend to be treated in eye departments, whereas patients with breast cancer tend to be treated in cancer departments. So the cancer departments have got all the resources. They've got psychologists and lots of information and lots of infrastructures and so on. When we go to our managers in an eye department and say, oh, we'd like this and that, they say, no, sorry, we can't afford it. And then you say, well, these are cancer patients, and why should they have less than the breast cancer patients? And then they say, sorry, we've got to prioritize cataract because that's what brings the money and that keeps the department open. Luckily in Britain, I was funded by a committee in central government. So when my managers refused anything, I was able to call the cavalry. And they used to come and tell the hospital that unless you give them out of these things, we're going to stop funding you. And so they very quickly gave me what I wanted. If you don't have that here, then I think there's the AOMA or the patient advocacy group. If you had a collective voice, if you had a checklist of standards that must be met, and we were able to say, look, if you don't give us these things, you're going to have all the patients from the whole of Australia, exposing you in all the newspapers and all that, and you better give us this machine that we must have in order to be the same as Britain and America or God knows where, you know, then that would help improve things. That's how I got a data manager. I was saying that yesterday, that in England, I didn't have a data manager, and I was expected to do lots of audit, quality evaluations and all that. I said, well, in the United States, they've got data managers, why don't we? And so they gave me a full-time data manager paid for by the hospital, not dependent on research grants, and that transformed my practice. And that worked really well. But when I was in America and I said, in England they've got data managers, it didn't work at all. But you've been to two departments. Glenn, you can speak to that, can't you? About the difference between an eye department and a cancer department.
Oh, yeah, definitely, you know, pretty well with the eye department, there's nothing there. And that was it. You know, you've got a doctor's surgery and that's the eye department, where the cancer is, as they say, a cancer centre. Breast cancer, as soon as my biopsy came back and said, I think it was whatever, one positive, whatever it was, chemo, you know, the treatment there, everything, yeah, you just can't compare it. But to actually do a change, do we need to lobby our politicians? Would that be any good?
I think patient power can be really beneficial here.
And
gang up together.
yeah. Yeah, so if we need to gang up together, we do have our platform with the Facebook group. Whether that is good enough or not to lobby the politicians, I don't know, because sometimes some of those groups are seen as being good, some are seen as bad. But at least we can give it a go. Thanks, Susan. That's a good idea for you.
We do have a federal election coming up. How many votes do we have in the room?
Promises, yeah. I've got some questions that just been bothering me. I have my test done every 6 months. So a week before and after the test, I'm walking on eggshells. But the test they do are for my liver and for the ultrasound for my tummy or whatever. Once in a while, if it shows something funny, then they do another test. Of that 2 occasions, I had repeat chest x-rays done then, and it says that I've got nodules on the lungs. Repeated test, I said, oh, then it's just your bronchial pneumonia. When do I start to worry? Because, as I said, I never fit any of the statistics except for the small Asian percentage. I'm small. And other than that, I do not come under any of those. The chances of it coming back other places, it scares me. But when I go for the test, the last test I had just in March, says that there's a chance of a pancreatic leak. I went to Dr. Google, and it says a high risk of pancreatic cancer. So of course, I'm literally screaming my house down. I want to know. It scares me. But then when the tests come back, they say that it all depends on how the radiologist is looking at the picture.
Yes, that's definitely true. We don't have any radiologists in the room. There's definitely an art to the science of radiology. So sometimes the pictures have to be done again. Sometimes you have to have a different scan. And sometimes you have to have a CT or then an MRI, or sometimes an MRI, then a CT or an ultrasound sometimes. So it depends on who's doing the test and depends on who's looking at the results as to what they think is going on. And sometimes we don't know. So I have a few patients where, for various reasons, the scan is obscure, and we say, well, we have to just repeat the scan. If this is a cancer deposit, then in 2 months' time it's going to be bigger, but it's going to be 3 millimeters and instead of 1 millimeter. At least I know then it's growing and I know what to do with it. But we have meetings with our radiologists. So sometimes in the course of those meetings, what happens is they say, well, Jacinta had a scan 6 months ago and a scan 3 months ago and then a new scan. And the radiologist will say, well, I didn't know she had a scan 6 months ago. So let's look at that one and let's look at them all together. And so sometimes they will then go and look at them all together in these, what we call MDTs, multidisciplinary meetings. And so then they'll look at all the scans together, and when your oncologist can talk to the radiologist face to face and say, look, I know you looked at the scan 3 months ago, but you didn't look at the scan 6 months ago. And so maybe it's changed from 6 months ago to now. And so one of these nodules may have gone from 1 millimetre to 7, but it was 7 millimetres 3 months ago. So what your report says it didn't change. It didn't change in the last 3 months. But the important thing is that you went back and you looked at the scan from a year ago, and then it did get bigger. And now maybe we do have a problem. So if there's some doubt, it always is worthwhile asking your oncologist to talk to the radiologist face to face or on the phone and say, look, this is the context, this is the type of cancer, this is what I'm worried about, this is how many scans Jacinta's had, and can you please give me some more detail? And the radiologist may say, do another scan, do a different scan, or sometimes what we've done is we've treated patients with antibiotics. We're not sure if it's an infection, give them some antibiotics and do the scan again 3 weeks later. If it's an infection, it would have got better and the scan will look better.
I've been told that my immune system is bad, right? And I've been put on antibiotics. And now I'm on steroids now for a whole year because of rheumatoid arthritis and polymyalgia.
Oh, well, that's going to complicate the situation for sure.
Exactly, but that's what I want to know is, in the sense is, if something, because since I don't fit the criteria, I want to know early so I can get the help as opposed to waiting for 6 months, which may be just a bit too late.
Well, hopefully whatever scans you're having will be done frequently enough that that it won't be too late, that they'll catch it.
Yeah, I don't have an oncologist. I see Dr. Giblin once a year.
Right.
And my GP every 6 months, he sends me for my tests.
Mm-hmm.
So what should I do?
You can, I can talk with your GP if you like, or Dr. Giblin, and we can try and work out what we need to do.
I'd appreciate that.
Okay.
It's scary.
No problem.
Thank you.
I've got a couple of questions for patients. I'm sort of hearing that there may not be the vocabulary that we all share and know. So I just wondered how many people know that there's a difference between a medical oncologist, a surgical oncologist, and a radiation oncologist. So we have some insiders who do. What about others? And do you know where the ophthalmologist falls in that spectrum? So it's quite tricky in this disease because the ophthalmologist is often the surgeon and will act as the radiation oncologist and put on the plaque, whereas the medical oncologist is someone that treats systemically with medications or drugs. So I wondered if it would be helpful to this community to have perhaps a list of specialists for your disease and what they do. Is that something that, yeah? Okay, and
Can I say something to that after you finish?
Oh, yeah, I actually have the other question that I have from the testing end, and it kind of rolls on from things that Jodee and you have mentioned, and Anthony. We talk about the immune system in melanomas, and the eye is actually a really interesting space because it's immune privileged. So immune cells do go in there, but they talk differently to the tissue that's in the eye. And what's really interesting about uveal melanoma is you see lots of lymphocytes in there and you see lots of macrophages. They're all immune cells. But the more of those you see, the worse the prognosis. And that's exactly the opposite of cutaneous. And I think that just goes to show that uveal melanoma is talking very, very differently to the immune system. And we just know so little about the biology of this tumour, which really leads me to the research question. And that is, how many people in this room, if fluid or tissue was taken as part of their treatment, and if there was something extra left over, how many of you would be willing to allow that to be used for research? There's quite broad support. And okay, so lymphocytes are a type of immune cell, and they walk around and they can produce antibodies, or they can just attack dead cells, and macrophages are also a type of eating cell, and they can also present antigens or tell lymphocytes, hey, there's something really abnormal with this cell, and this is the antigen you should be attacking, this particular protein. So we can put that on the website. But what I wanted to ask is, so we're putting together a national collaborative research effort, and at the time that doctors see you, that's an opportunity to invite you to be on a research program. And what I'm interested to know is, when would that be appropriate? Because when you first get that diagnosis from Max or John or Mike, is that too challenging a time to be asked that question? Would you rather be asked it later, post-operatively, or when you see Anthony? Like, what's the time that would be appropriate for that? Would you like to participate in research? Or would you even just like to say, I would like to be contacted later for someone to talk to me about a research?
When I was diagnosed, and it was within 5 days of when I had my eye go really funny. Within 2 days, I went through the levels of GP to eye to here down to John, and what I really liked about John's talk to me was, here are the risks. So I was prepared for my inoculation well before it happened, knowing that if that happened, then the next one is going to be this, then the next one's going to be this. And I think that's really important, because I think I had a lot of time to adjust well before it happened. So I was already adjusted when I said, yeah, well, that's what has to happen. I don't know if that answers your question, but if there's anything I can give towards that during that time, I said, what do I need to do? How do I need to participate in this to lower the risk as we go?
I think it's an individual thing. Like, I think for me, before I saw my specialist, I was already mentally prepared that that's probably, enucleation was essentially my only option. And I think if he had said, even though when he confirmed it, sorry Michelle, you've got no other option other than to have your eye out, if he had then said, do you want to participate in some research, I probably would have been on mental overload. Now, I'm a visual person, so I think if I was given some information, you know, like, here's something to think about, like you said, here's something to think about for perhaps later, you know, in my Google searching, if there was like a website like there will be, if there's links on that if, you know, if you want to participate in research, then, you know, press this email and, you know, submit your details then. I think for everybody there is going to be a good time, but it might not be that first visit, might not be the second visit. For me, it took me probably 18 months to get my head around having been enucleated to then go, well, I'm going to be my own advocate. I'm going to start researching the guts out of this, find out what sort of surveillance I feel like I need. And then if, you know, I had have found I could have been part of a research program, I would have been bang straight on it. But like I said, that was, for me, it took me that long to get my head around what had happened.
Do you think if all the information was available, say for example, at an AOMA website at the time of your diagnosis, would that have helped you along your journey?
And again, as everybody has found, a lot of my searching went to America, and there was very limited, thank you Susan, you know, very limited on social media. And, you know, the first place I went to was an American Facebook site, and everybody was talking about, you know, their own stuff. And when I found the Australian one, I went, oh, thank God. But again, it wasn't available 3 years ago that I found. So, but yes, if it was available straight then and there, I would have been all over it.
I have, oh, sorry.
Has there been any studies, comparative studies of a healthy member of that family, you know, in a similar role, to say what this person's got, the others don't have, to give a clue as to some highlights?
Do you mean in terms of
risks?
risks?
Yeah. So we actually talked about that yesterday. So there, in terms of risks of ocular cancer, so there's a couple of genes, just literally only one or two, and if they're mutated, members of that family get ocular cancer and a few other cancers. So usually that's a nice big red flag. But there are also lots of genes where it increases the risk of getting cancer by 3%. And so we actually don't even know what those genes are. We talked yesterday about they're trying to collect blood from 500 patients and 500 controls who don't have ocular cancer to understand if there's a gene that puts a risk up of 3% of getting ocular melanoma. We actually don't even know what it is at the moment because the cancer is so rare and no one's gone collecting blood on 500 cancer patients, although Queensland are doing it. Yes, that's what we were talking about. Yeah, do you want to answer that? Sure.
500, come on. So my name's Jane Palmer and I work at the Queensland Institute of Medical Research, QIMR Berghofer in Brisbane. And I work with Professor Nick Hayward. And for the past 30 years, Nick's been working on cutaneous melanoma. And so thousands and thousands of very generous people and their families have donated samples of blood and tissue and saliva. And they've contributed enormously to the understanding of cutaneous melanoma. And with international collaboration, they've located that there are about half of the people with cutaneous melanoma have some known genetic predisposition to developing cutaneous melanoma. But the other half is still a mystery, and we're still looking at those people within families that we've been following for 30 years. So about 6 years ago, we started looking at people with uveal melanoma, and ocular melanoma, but with a particular focus on uveal melanoma. And so with uveal melanoma, there's only a very small portion of known predisposition genes, which is talked about by Max today, the BAP1 gene, which has mesothelioma and a few other cancers. So we're looking at rare types of cancers, and particularly rare other cancers that are associated and their family members. So we recruit people. It's a fairly unobtrusive. A phone call and, you donate your sample of saliva, put it in the post, we have a chat, and we do recruit family members and we follow families over time. So yes, certainly there is an avenue. And the 500 is the minimum number, my goal that was set by Nick when we first started this work, and we were very keen, and he said, well, you'll have to reach 500 people with this rare cancer to be able to give us some fairly basic information. And so we have reached the 500. So now what we want to exceed that 500, so we're collaborating internationally, but of course we welcome 501 and 2 and 3 makes a difference, because the more we put in the pot, the more little things that we'll find. Exactly. It's not a test, I have to say. We're not an accredited laboratory for providing any sample results. So it's not a test, it's exploratory research. So it's not a test that's an individual test. It's not like what Svetlana does, and it's not like what a geneticist would do. I think that Max would, if someone came to him who had a family history with, uveal melanoma, mesothelioma and a kidney cancer, you'd be sending them off for genetic counselling, because they would be suspicious that they would have that BAP1 tumour predisposition syndrome. But these are for the mysteries, the people who have got other cancers within themselves, multiple cancers within themselves, which we have found in our 500 or so people that we've looked at. About a third of them have uveal melanoma and another type of cancer. That's really preliminary data, it's really early, it's not published, and we're still looking, we haven't finished. So yes, we're very interested in recruiting people for our genetic studies. But all of this is as part of this Australasian Ocular Melanoma group, because together we will not do it alone. We can't do it alone. It's only by everybody joining in together that we can.
The children and the grandchildren will be able to have a better chance at treatment.
And early diagnosis. Yeah.
I'm the first one in my family to get this, and as I said, the reason I say it's scary is I do not exactly know what to look for, what to do, what should I not do. And I can't really it's hard to explain. I can't really ask. So what do you do? But like breast cancer, you can say, okay, I've got a family member that's got breast cancer, I can ask. I've got a friend that's got breast cancer, I can ask. Who do I ask?
Well, I think that's the really positive thing about being involved in research. And I think that makes you feel, you know, not only can you be active in being involved in standing up for yourselves, but you can also be active in being involved in research. People say to me all the time, it may not benefit me, but I do hope it would benefit others.
I joined the Eurasian group also, and since this hit 4 million of my kind, I'm the only one that's different in a sense. And because I've also got polymyalgia, which is also a lean back towards Caucasian thing, I tried to join the Asian group and ask them, are you guys willing to just sort of, they've got doctors on their panel, to at least run some tests, but no one wants to step up. You know what I'm trying to say? They should start. Don't wait till 10,000 men fall down with this, not white, not, no,
you start, that's it.
Exactly, and I am just a layman. I'm just a layman. I need some doctor to stand up and say, okay, I will take your blood now and test you. I'm sorry. Sorry, none of them are even willing to do that. Just one person stand and say, okay, I will test and I'll find. You will get the accolades if it goes far. I get the pinpricks. But someone step up.
Oh, there you go, Jacinta. We jumped up. And we are all jumping up as a group. You know,
I have one testing question that I think I really would like to. I get this comes up a lot in MDT. So at St Vincent's, every eyeball that comes to me with uveal melanoma, I do a prognostic molecular test, and there's now overwhelming evidence that you can give the risk stratification from virtually no risk of metastasis to certain risk. And I don't know to what extent patients actually want to know that and what sort of counselling they want before and after that test. And whether you think it should be offered as a standard of care for uveal melanoma.
We should get all the information everyone, but it goes to individual at the same time. How do we want to know the chances of what can I or can't I do? I need this information and just waiting for someone to tell me.
Before we were asked the difference between a radiation oncologist, a surgical oncologist, a medical oncologist, I'd like you to consider for a moment what's the difference between an ocular oncologist and an ophthalmologist. An ophthalmologist, an ocular oncologist knows how to treat tumors, and an ocular oncologist knows how to speak to patients with cancer without getting upset. I mean, the first cataract I saw, I passed out. When I started speaking to cancer patients, I was very, very upset. And then after I got used to treating adult patients without getting upset, and I had to treat babies with retinoblastoma, I had a hardened skin for adults, but I got upset by those children with retinoblastoma. And then I got used to that, and I was able to speak to the parents calmly and so on. So general ophthalmologists have not been through that, and so you might think that they are not interested in speaking to you, or they're being cold and distant and so on. But my suspicion is that many general ophthalmologists, when they see patients like yourselves, are themselves upset at having to share bad news with you. And if you can just understand that and be a bit patient with them, then that will help the collaboration that you have to go through. Because I've heard so many patients complain about their ophthalmologist who didn't tell them something or told them something in a bad way, but they just haven't learned how to do so properly. Not through any fault of their own, but just because they're not oncologists.
I was going to ask the patient group a question, which is the question that I see of long-term follow-up. Bertil, I think, said that he had to discharge so many patients from his clinic to fit in more patients. And whilst there's a drop-off with time of our patients, there's also an elongation of treatment intervals. Some patients want to come and see us once every 2 months. Some people never want to come and see us after therapy. How long, in general, have you been sort of seeing your ophthalmologist frequently? And what was your experience when those intervals elongated? Did you feel comfort, or did you feel that they were just sending you off on a random chance that something might occur? Someone who's been treated by a plaque, clearly, if you've had an enucleation, I think it's a little bit different. We would see you occasionally, but if you've had plaque treatment, we don't keep on seeing you frequently forever once we feel happy. Is that conveyed to you as a patient group that we think the local disease is under control?
Hi, I haven't had plaque. I had external beam radiotherapy. I have been seeing Willie Campbell probably every 6 to 8 weeks for coming up to 3 years now. Initially, I think I would have been happy with an extension of that time, but I did develop edema, so I needed anti-VEGF treatments. I had one a few weeks back. Prior to that, it had been sort of 18 months since the last one, and we were slowly extending the time between treatments, or visits, sorry, to 4 months, and we've actually kept it at 4 months at this stage. But yeah, you get well, it's not a codependency, it's probably dependency on my part, that you just feel comforted when you have the tests repeated, and yes, there is either no growth or the lesion is stable. There's been no more edema that's developed between visits. So yes, I think that's going to be a very individual thing too, as to when patients feel comfort that nothing bad's going to happen. And certainly I've always been given the opportunity that, okay, we're extending the time, but if something goes wrong, or if you're uncomfortable, or if you've got any concerns, you can always make an appointment and come back and see me at an earlier time frame. But yeah.
Can I ask a question? Anti-VEGF, for everyone's benefit, is something that stops the blood vessels from growing, and we use it to treat edema. I have a question for Bertil, John and Max. How often do you use anti-VEGF as a prophylactic? Because I know that Shields is using it as a prophylactic. I was talking to Leanne about it earlier today. By that I mean we use anti-VEGF just to prevent growth rather than actually treat it.
It's not only the Shields, but also the Swiss group that found that with big tumors, leakage of fluid from the irradiated tumor is quite predictable, and so they start giving injections sooner rather than later. And I think that's a practice that is becoming more extensive.
Down my end, I would say that I actually wait for symptoms or signs. I don't pre-treat or preempt. My view is that anti-VEGF injections are, if you start them early, I don't think there's any evidence to say that you've got a better long-term outcome. Maybe you won't have that psychological issue of a drop-off in your vision at some point, but I think that if you've got an open door policy of saying turn up if you've got a problem with your vision, I think my personal view is that the treatment is just as efficacious if given at that time. That's my personal view.
And in many patients, the Avastin doesn't work, and you end up having an Avastin addict, and the treatment doesn't work. And another option is either to give photodynamic therapy to the irradiated tumor, or transpupillary thermotherapy to shrink the leaking tumor, and that can help quite a lot.
I agree with Bertil and John. I tend to, well, if a lesion's a high-risk one for developing visual problems from the treatment, I do have a discussion with the patient about the possibility of starting VEGF earlier rather than waiting for symptoms. But of course, it's a risk-benefit ratio. You've got to consider that once you start, as Bertil said, you've got to continue. You know, it's a series of injections that have to be repeated at the moment. So I don't think it hurts to have the discussion, talk about it, think about that option. But in practice, I find most of my patients are starting to have that treatment once there are some early signs.
Thank you.
So John, just going back to the question on when we want to, where we feel comfortable. Unfortunately, I had bladder cancer 3 years ago, and I'm on surveillance. So it was every 3 months, and then for about a year and a half, and then it went to 6 months. But what made me feel good is the confidence that was exuded by the specialist to me, and the knowledge and the data they had. And I guess the bladder cancer is probably a much bigger pool than the ocular melanoma. So I think getting the confidence from the professionals, from you guys that see a lot more than we have, is what we're looking for. It's saying, look, if you feel this way, then you should, if you can give us if you feel this way, then you should do this. Like when we had, December 14th, and then come back March 14th, and my eye was removed February 8th because of what I was feeling, and I said, hey, I think there's something happening here, and things happened. So I think as we're learning more and more and getting more and more data, maybe the patients or the consumers have a thing to say, this is what I felt, and it might be a one-off, it might not, but only you would know, or only the research people would know. So I'm looking for confidence.
Ongoing surveillance of the eye afterwards. Look, I'm 5 years out. I've been reviewed essentially, other than 1 3-month visit, 6 monthly onwards, which I'm quite happy about. I wouldn't like to be seen any less. One of the issues is, some people do like reassurance and whatever, but you also have to consider that in the long term, we're talking about a malignancy here. We're talking about a cancer. And I think, scanxiety is real. Having imaging done, and certainly having a checkup, it does make you anxious before and right up until the point where the ultrasound goes on your eye and you see that the thickness hasn't changed or it's gotten smaller. You look at the photo with Michael Giblin, and you see that things haven't changed and you feel somewhat reassured. So having more often it may not be more reassuring, it must make you more anxiety prone.
Just coming as an oncologist, I think Gary's sort of summarised it really. This is something that we're always doing. We're always following up patients with scans or examinations or tests or something, and we're always changing the follow-up duration over time. And in the end, guidelines, policies, accepted standards are what people go by, and then they always make it very clear to a patient, of course you get in touch with us if you're worried in between times. But because there is a framework, there's a certain accepted standard, and people are told that from the beginning, I think everybody feels very comfortable with that. And so it's not an individualised process. Okay, you get the odd patient who is extremely anxious and prefers more investigations. You spend a lot of time trying to wean them off those investigations. But most people, I think, have Ian's experience. Scanxiety is a really big problem. And we're very good at finding tiny little things that really are of no clinical significance, but we feel obliged to tell people about them, and so more scans are not always helpful. So I think in the ocular melanoma space, as we come towards having a kind of national approach to things, it will help with those sorts of problems, because you'll be able to refer to the document and say, we've all agreed on this, you're going fine, we're going to follow the protocol.
Yeah, I mean, my view would be that at some point in time, I think that it's always important, if you've had one eye treated, particularly if you've lost vision, that you're going to see someone regularly, even if it's just to have a look at the other eye. I keep saying that that's the most important insurance that you can actually give a patient. But there is a point where we start to see, 5 years plus, certainly, in our hospital clinic, we're trying to change that into a long-term follow-up clinic so that people can feel comfortable. We give it a name. They can feel comfortable, and that's what happens in a lot of other cancers, is that you go through your acute treatment phase, because in reality, whilst it can recur very late in the eye, it's the systemic recurrences that are probably far more critical. And from the ophthalmic point of view, we'd prefer that you probably direct your care to general oncology rather than ophthalmic oncology at a certain crossover point. I don't know where that is, and it might be different for every tumour, it might be different for every patient. But if you try to create guidelines, you've actually got to have guidelines which patients are happy with. Otherwise, if the recipe book looks wrong, no one believes anything in it.
What I've found very useful is alternating visits between the oncology centre and the referring hospital. And like that, you gently wean the patient away from the oncology centre, and they need to travel less. The local ophthalmologist becomes more comfortable about taking over the patient's care, because a lot of ophthalmologists are afraid to look after a patient. But if you alternate for a while, then it becomes easier to make the transition when the time comes.
I just wanted to add, and probably more specifically to when you said, does it make you feel more confident or does it make you feel worried? And I think there's a mixture of both. I mean, especially, when I was in your treatment, and then also even, post-operatively and into my stage 4 management, I went from a stage at some points being scanned every 2 weeks. And even for that to be pushed out to 6 weekly was absolutely terrifying. And there's that sense of confidence that comes from it, that obviously it's, stabilised and we've got to that point of view. But I would still experience that scanxiety heading into every 2 weeks for a while. And even when it was pushed out from 2 monthly to 3 monthly, at that 2 monthly mark, I would notice a peak in my personal anxiety levels without actually realising. And it was only when I looked at dates and realised, I'm sitting exactly where I should be having scans, and that's why I'm experiencing the anxiety. But it also did make me feel more confident that my ongoing treatment is going well, and obviously that where we're at is at a good spot. So there's to and froing, and there's a lot of emotional turmoil there. But I think it's each and every individual and how they're going to take it. But it's important to push it out and continue to reassure the patients.
John, you just triggered something for me with the fact that looking at the other eye, and certainly, and this is from going over to America, they very much promote, all of us that have got uveal melanoma have diminished vision in one eye, and they're recommending that all of us should wear polycarbonate lenses at all times to protect the other eye. Is that overboard? Injury, accidents, things poking in it, that sort of stuff. I'm sitting next to someone with one eye who's not wearing anything.
I had someone when I was doing the Kokoda track, and I got spammed with some emails telling me that was it you? Sorry. But it was like, are you taking these glasses? I was like, no, no, I'm not. Sorry, Ian. I thought it was coming from America.
Yeah, because on that matter, when I saw Dr. Conway after one of the operations, I said, how soon can I get back to chainsawing up trees for my firewood? And he looked at me horrified. I haven't as yet, but I've always previously have had protective glasses plus a face shield. Now, I haven't gotten the courage yet to use a chainsaw chopping up trees. I've done a little bit of work. But I know you've got to be very mindful of what protection you have for the one eye that we have left.
So the question of where people have eye injuries in Australia, it's in the garden at home, and for those people who work in an industrial environment. So those are the two places that you need to be really careful of, because even if you just get a bit of grit in your eye, if you've only got one eye with decent vision, it's disabling. If you've got two eyes, well, you can always just shut one and continue on. So at a practical level, it's a common sense idea. There's the other question of wearing hats and sunglasses. A hat will cut down 70% of the UV light. Not that this is a UV light related cancer, but if you are prone to uveal melanoma, you're probably prone to skin tumours. And so just simple things like that are appropriate, and just wearing glasses without any visible light tint cuts out a fair whack of the UV in any case. And I think up here there's about 50% wearing glasses of some sort, so they've got the easy choice. But yeah, eye protection I think is appropriate, and certainly eye protection for young people. If you look, that they've done statistics on young people who've got a poor vision in one eye, and if something's going to hit them, it's going to hit their good eye, because that's the thing that they're lining stuff up with, and it's the one that they've got open. And if something's going to hit something, hit one of their eyes, it's the one that they're actually looking with.
Yeah, and the other thing is, I went for a steam train ride. So one of the things steam train ride, and they have the ash. So what I did is I actually put one of my eye patches on to cover up where my prosthesis was, because just in case some of the ash got in there, and I wasn't going to take any risk at all of even getting the prosthesis scratched with some of the ash coming out.
So in Melbourne, we've got a train called Puffing Billy, and it's renowned on a nice sunny weekend when people have stuck their head out the window, and they do have clouds of ash coming out. So that's one problem. The other problem that Melbourne has is that it has trams, and they used to drop sand out of the in front of the wheel when they were braking to give them some traction. And when you get sand that goes under a tram wheel, it goes in all sorts of directions, and you can just be walking along it and get a spray of sand. So if you're coming down south, those are the two things to avoid. We don't have so many snakes, but you know.
Yeah, can I ask about blue light? They're saying the blue light is bad for the eyes, so how will that affect?
The ultraviolet hazard, and then the blue light hazard, which is the things that people have talked about. Part of the hazard of opening up your computers at night, and should you do that because it may change your circadian rhythm. That's one of the issues. The other issue is just simply the ultraviolet light. I mean, our eyelids and our eyes remain the most sun-exposed part of our body. Per square centimetre, your eyelids are where you're more likely to get a BCC than anywhere else because of that. And I think that common sense precautions in that area are appropriate. They also talk about the macular degeneration risk, and I think that there are probably other risk factors which are much, much higher, but it's one of those that's included. And macular degeneration 100 years ago wasn't a problem because we never got old enough. But if you look at the number of diseases and the ageing population, they've done surveys looking at the increase in services that are required by various health services. And ophthalmology is experiencing not only services related to an increase in ageing population, but as you get older, the number of problems you actually have to deal with goes up exponentially. And so as opposed to ENT, the number of eye procedures was sort of supposed to double compared with them because of theirs is very much more skewed to the younger age group rather than the older age group. So I think that we'd all be advised to be cognizant of UV and near blue light hazards.
Yeah, I have a burning question to the clinicians as well as the patients and people that have experienced uveal melanoma. From the data originally from Dr. Damato, and we know from Svetlana's talk how well you can define the genetic characteristics, together with the SHIELD study have shown that indeed the patient, you can not predict which patient have high risk or not to develop metastasis. However, the biopsy is not done across all the centers equally. And you mentioned that in Liverpool was done almost 100%. In your new practice is not done that frequently, and I know in Australia varies a lot. And I would like to know what is the obstacles, whether it's issues around practice, around experience, but also around the confidence that patient may have or not on the complications. So I don't understand what the reason is that the biopsy is not done basically in everyone that have uveal melanoma.
It's very difficult to do a biopsy without damaging the eye. And it's difficult to get a big enough sample, especially if the tumor is small. And it requires a lot of practice to learn how to get a successful biopsy without causing complications. And even then, sometimes you fail to get enough tissue, and the patient gets very upset when that happens and disappointed, or you can cause a hemorrhage. And it's not just the actual collection of the specimen, but the specimen is very small. The transport to the laboratory has to be efficient. The laboratory have to know how to handle small specimens without losing them. And they need to have the tests to analyze these specimens, and these tests are not widely available. So you need to have a lot of opportunities to gain experience by treating lots of patients and doing lots of biopsies. And not everybody has got enough patients to patients with TS, not enough opportunities to learn to do this safely and properly. And then there's also the problem that a lot of patients are going to get metastatic disease, and they're afraid that the biopsy will cause the metastasis, or the ophthalmologist is afraid that if the patient gets metastasis, the family and the patient will blame it on the biopsy. And even if we say that it's not likely to happen, there's never any certainty about that. Well, what we've been doing in Liverpool is doing the biopsy after the radiotherapy, the week after the radiotherapy, on the last day of the radiotherapy. So like that, everybody's happy that you can't seed these tumor cells onto the conjunctiva, and you can't blame any metastatic disease on the procedure. But that depends on the test that you do. If you do the Castle test, for instance, it has to be done before the radiotherapy. But with other methods, then you can do it after the radiotherapy, as long as it's soon after the radiotherapy, when there's still tumor there. Do you have anything to say about the biopsies?
But we've coming together and actually putting together guidelines. Is that something that should be somehow, whatever is required, training or to kind of increase the ratio in which is done?
I don't think one is being fair to hospitals and to surgeons just by having guidelines, because they create expectations that can't be met, and then those expectations cause lots of problems. I think it's much better to speak about aspirations. Aspirations. What we would like to do if we can. Now, I'm having this dilemma myself, because in Liverpool, I saw the patient in the morning, and a few days later, Mr. Grenville did the biopsy. But in London, I don't have that luxury anymore. So I have to tell the patients that the surgeons here cannot do a biopsy on a tumor as small as yours. If you want a biopsy, you'll need to go to Liverpool and get the biopsy done there. And I'm happy to say that to them. But some patients say it's too far to travel and so on. And it's not because there's anything wrong with the hospital in London. It's just that this is a stage of transition, and everyone's trying to reach that destination. But some hospitals have better opportunities than others.
Okay, we're pushing 4 o'clock. So has anyone got a one last question or comment? Ian?
Sorry, Anthony, I was just going to add in that, look, my feeling about, and the issue is, from a social media perspective, everyone in the US is talking about what the genetics of their own particular tumours are. Although I recognise that certainly it comes at a cost, and the time and the trouble that you've just talked about of doing biopsies and some of the issues with complications. At least I think that probably we need to have, both on the AOMA website and also at a time when people are being consented for treatment, I suppose that genetics is discussed, simply because the genetics of this tumour seems to be so important from what we're hearing, and there's a lot of discussion around it. And people, I suppose, need to be aware that, as far as, donating tissue later on, donating blood, and also the fact that, theoretically, in the best of all possible worlds, maybe we do, that biopsy can be done, and that might give you an insight as to whether your tumour is going to metastasise. There probably needs to be a very clear information provision to patients. And certainly if I don't get the chance, Anthony, thank you very much for all the hard work you've done, and you and your team for today, and absolutely. But I know I probably won't have the last word on this.
Yeah, well done, I think.
Could I also say thank you to the Max and Svetlana and Bertil, who's come such a long way, and John, who's come from Melbourne, and Claire, who's come from Melbourne, and Peter, who's come from Adelaide, and Ellen, who's come from Perth. Who have I forgotten? Yeah, big thank you. Oh yeah, Jane, thank you. Big thank you. This has been awesome, and thank you to all the patients who have come.
I've just got a quick question. If all the popular cancers are getting the money, would a significant research breakthrough in one of them affect the treatment of OM, or is OM so different than the others that it's not going to help?
It might help. So we work with a few pharmaceutical companies doing new cancer breakthrough drugs. They're called early phase trials. And as an ocular melanoma doctor, I sit in those meetings and I say, we want to give this to colon cancer, we want to give this to breast cancer. And I find myself often saying, what about ocular melanoma? So, and actually that's been successful on a couple of occasions. So we've got this trial starting in a few months where the company didn't have any idea about, didn't even know what it was. And I said, look, I think this drug might work in ocular melanoma. So they said to me, and they said, why? And I said, look, I think there's the drug's targets there. And they said, well, prove it. So we did. And so in roughly 4 to 6 months' time, this drug is coming to Australia. They've specifically said, because of the stuff that we've provided them here from the Kinghorn, that Svetlana and I worked on, they're going to put 20 patients on worldwide because of that advocacy that we put forward to put ocular melanoma up there. So we have those conversations regularly, and if there are some drugs, sometimes what happens with some of these drugs that like this other drug was developed for skin melanoma, So they tried in ocular melanoma. So these things happen, and as we understand what makes the disease work, then it may be that those things come forward. So one of those genes and that motor pathway I showed, that was a gene that came forward from colon cancer, and it's only now 5 years after those trials are negative that someone's done some research in the lab to just actually need to rehabilitate those drugs and go back to ocular melanoma. So I'm sure that in a few months' time, someone in the States is going to get those drugs out of a cupboard, start giving them to ocular melanoma patients, and eventually we'll find out if they work. But sometimes things don't go in a straight line. So we are keeping our eye on the ball, so to speak, but it's a challenging non-linear process. Sometimes we discover something about a drug that was 20 years old that we need to start to use again for cancers. So it's a difficult process. But anyway, thank you all very much.